You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for February 2nd, 2018. This will be a special week for This Week in Cardiology, and I'll have just 3 topics. Mostly, I'll focus on the Castle AF trial, which is a landmark trial in electrophysiology. But before that, I'll mention 2 important topics that came up this week, one on the drug Loperamide and a second on heart failure quality. So first, Loperamide. Now, this summer, I want to tell a story. I looked pretty smart up in the ICU. A young patient with a history of drug use came in with syncope and a bizarre-looking wide complex rhythm on her ECG. It's as if she had overdosed on flecainide. Now, type 1C antiarrhythmic drugs like flecainide are sodium channel blockers. Too much of them make the ECG look wide, like someone pulled on both ends of the ECG and stretched everything too wide, the QRS and the P-wave. I wondered out loud if this was Loperamide abuse. And I had first seen a case on Twitter, that's right, Twitter, from a toxicology lecture by Canadian pharmacologist Dr. David Gerling. It turned out that I was right about Loperamide. The doctors went back in to talk to this patient, and she admitted to taking bunches of the drug, Loperamide, which is also sold in America as Imodium. She took it to stem opioid withdrawal. The Loperamide in Imodium is an antidiarrheal medication. The patient got better with supportive care, and I've seen numerous abstracts and posters at heart rhythm meetings describing the observation that at high doses, Loperamide acts as a sodium channel blocker and has flecainide-like effects. And this week, the FDA announced new action to counter the growing problem of abuse and misuse of over-the-counter Loperamide, which is usually, as I said, used for diarrhea. The FDA is asking manufacturers of the drug, which is available over the counter and by prescription as well, to change the way they label and package Loperamide. They're basically asking for voluntary changes. And the clinical point here is that here in the U.S., we are immersed in an opioid epidemic, and people are going to seek relief anywhere they can. They will take Loperamide because of its opioid-like effects, and if they take too much, they can get into proarrhythmia, and it's important for clinicians to recognize this. Second topic is heart failure care in the hospital. Now, hospital volume is often used as a structural measure for assessing qualities. Busy hospitals do better, for instance. Well, authors involved with the Get With the Guidelines Heart Failure Registry sought to determine the relationship between a hospital admissions volume and the process of care metrics and long-term outcomes. This was in 342 hospitals in the U.S. It involved more than 125 patients. Lower volume hospitals were less likely to be adherent to heart failure process measures, like prescription of ACE and ARB and beta blocker, etc., compared with higher volume hospitals. Higher hospital volume, however, get this, was not associated with in-hospital mortality or 30-day mortality, nor was it associated with 30-day readmissions. These findings are interesting because they show that busy hospitals do better at complying with process measures, but that didn't translate into making a difference in outcomes. The authors of the paper make the point that hospital profiling efforts should not focus so much on volume, and this is similar to what has been found in cardiac surgery and PCI. I'd also add that this finding raises questions about the utility of complying with process measures. Low-volume hospitals did worse on process measures, but this did not change outcomes in the short term. And my message, just from the clinician and from the bedside, is that people in the quality of care business talk a lot about structure and process and outcomes, but I'd argue that outcomes are what we are after. And I'm not at all surprised that adherence to process measures like prescribing certain medications makes that much difference in outcomes. And this is because most patients that come to community hospitals like mine with heart failure are not young people with isolated cardiomyopathy. Those patients would do great with process measures, prescribe all the right medicines, for instance. But most patients who come in with heart failure are elderly. They're complex because of their many comorbidities. They have low blood pressure, chronic kidney disease, they're frail. What these patients need is individualized care that's delivered carefully and slowly and often with fewer process measures. So that's it for the second topic. Let's move on to Castle AF, the landmark trial published this week in the New England Journal of Medicine. Investigators from Germany, US, Australia, and 30 other countries randomized about 360 patients with heart failure with reduced ejection fraction and atrial fibrillation into an RCT comparing ablation of AFib or medical therapy. These patients enrolled in the trial all had ICD or CRT from Biotronic, and that meant they had the capability of monitoring AFib afterwards. The enrolled patients had symptomatic AFib. They did not have responses to antiarrhythmic drugs, or they had side effects to the antiarrhythmic drugs, or were unwilling to take the antiarrhythmic drugs. The primary endpoint was a composite of death from any cause or heart failure hospital admission. And the ablation group did better, far better. The differences were remarkable, stunning in fact. The primary outcome, 28.5% in the ablation group, 44.6% in the medical therapy group. That's a 38% relative reduction, 16% in absolute terms, and an NNT of, get this, about 6. Overall mortality was also significantly reduced. Death rates were 13.4% in the ablation group, 25% in the medical therapy group, a 47% reduction in mortality. The Kaplan-Meier curves were nearly identical for 3 years, but then began to separate after 3 years. Cardiovascular death, too, was the same, 11.2% in the ablation group, 22.3% in the medical therapy group. That's a 50% reduction in cardiovascular death. Left ventricular ejection fraction looked better in the ablation group. Now, as far as AFib goes, there was less atrial fibrillation in the ablation group, but ablation did not eliminate all AF. 63% of the ablation group versus 22% of the medical therapy group were in sinus rhythm at 60 months. About half the ablation group had recurrences of AFib, and they had an average of 1.3 procedures. Now, as seen in Table S10 in the appendix, only 18% of patients in the ablation group had an AF burden of greater than 10% during the study as compared to 45% of patients in the pharmacologic group. So the AF burden was significantly less in the ablation group. Now, the effect sizes of this study are incredibly large. A 47% reduction in death is greater than any known heart failure treatment. ARNIs reduced death by 35%, ICDs 30%, beta blockers 30%. Now, this degree of magnitude of change seems strange given that 50% of the ablation group had recurrences of AFib, which is not too surprising given that 2/3 of the enrolled patients had persistent AFib. Now, one hypothesis is that it's enough AFib reduction to make a difference. And supporting the author's conclusion was that the mortality curves do not change until after 3 years. If all the mortality benefit seems to come later and accumulate. Now, if the curves separated early, one would worry about confounding, meaning that the ablation group was substantially healthier. Another explanation of the results, however, was that the medical therapy did worse because they were sicker patients, had higher rates of diabetes, more use of digoxin, greater incidence of ischemic cardiomyopathy, and also 30% of the medical therapy group had efforts at rhythm control, which any AFib doctor knows can be hazardous in heart failure. The authors also note that the lack of blinding is a limitation of this study. They note that it would be difficult to do a truly blinded trial without a sham ablation. And blinding is important because ablation centers are doing the study and ablation proponents might treat ablation patients differently, not intentionally or maliciously, but just differently. An empirical study published in JAMA by Stanford authors in 2012, and I'll link it in the podcast, found that when studies with large treatment effects are retested in other trials, the treatment effects lessen. On the other hand, in favor of these findings are their consistency with previous studies. The recent camera MRI study from John Kalman's group found that restoration of sinus rhythm in heart failure resulted in significant improvements in LV function compared with medical rate control alone. The small CAMTAF, CAMTAF trial showed catheter ablation in patients with heart failure and persistent AFib led to improvements in EF, functional capacity, and heart failure symptoms versus rate control. And the ATAC trial, that's capital AATAC trial, found that catheter ablation of AFib was superior to amiodarone in achieving freedom from AFib. It reduced hospital admissions, and there was a trend toward lower mortality in the ablation arm. Now, a note on complications in the CASTLE-AF trial. And there were 15 complications related to ablation. That's about 8%. There were no deaths, but 8% is not typically what most doctors quote. We quote lower complication rates. I think many of us ablation doctors would be wise to look at the complication rate and potentially quote higher rates of complications. I also noted from the same table in the supplement that only one patient in the ablation arm of CASTLE-AF had worsening heart failure after ablation. This to me is very surprising, and it speaks to the robust health of the enrolled patients in this trial and also the excellent care that they received in the run-in period. Consider that half the patients in the ablation group got ablation outside the PVs, and still only one person gets worse heart failure after the procedure. In my experience, ablating patients with heart failure, especially when using ablation outside the PVs, exposes these patients to large loads of saline, as they're saline-irrigated ablation catheters, combined with atrial stunning, and heart failure after ablation procedure is a common complication that I've seen when ablating sicker patients. That said, let's accept the results of CASTLE-AF, and let's now talk about the big issue. And the big issue here is clinical translation in the real world to patients. I've ablated atrial fibrillation for 13 years, over 1,000 cases, and I can remember only a handful of patients who had heart failure and ICDs like those in CASTLE-AF. And that's about consistent with the fact that investigators screened about 3,000 patients to enroll only about 300. Though to be fair to the investigators, a third of exclusions were based on the fact that they had to have a biotronic ICD. Nonetheless, CASTLE-AF enrolled a very select group of people. Go to Table 1 in the New England Journal and look at patient characteristics. These were young patients. The median age was 64. No, this study does not apply to the elderly patient who presents with AFib and multiple comorbidities. 85% of CASTLE-AF patients, almost 9 in 10, were male. And this is a crucial point. Multiple studies have shown that women do worse with ablation. Again, we should be careful applying these findings to women with heart failure and atrial fibrillation. The mean left atrial diameter was less than 5. And so we need to be careful when we see blown out left atriums and really dilated left atriums. The median ejection fraction of CASTLE-AF patients was 32%. This means that these were a relatively healthy heart failure population. And in the subgroup analysis, patients with ejection fraction less than 25% showed a non-statistical trend doing worse with ablation. CASTLE-AF also had a robust run-in period where patients were carefully treated, I would say tuned up, if you will. If we don't stay true to the CASTLE-AF's methods and patient population, we are likely to severely harm people with AF ablation. And a final note on translation. Okay, you have a young male patient with an ICD and moderate LD dysfunction. He's doing well on baseline guideline-directed medical therapy until he goes into AFib. Then he feels terrible. You try antiarrhythmic drugs or cardioversion, and the drugs don't work. Atrial fibrillation recurs. His left atrium is not ginormous. This is a good person to do ablation on rather than pushing on with drugs or rate control. Now, I think most of us knew that, but now we have evidence that doing ablation skillfully and carefully may lead to better long-term outcomes for this patient. The investigators have done their job. Now it is up to us in the EP community including our professional society, to apply ablation wisely to patients like those in CASTLE-AF and not extrapolate to the vast majority of sicker, older, more frail people with heart failure. So that's it for This Week in Cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.